Hello everyone. After discussing the normal iron metabolism and all the relevant investigations, now we'll discuss the easier part, that is the etiologies of iron deficiency anemia and what are the clinical features. Etiology can be divided or it can be discussed under 4 headings. Iron deficiency due to decreased intake, due to decreased absorption, because of increased requirement, or because of chronic blood loss. Now we'll discuss them one by one. First of all, we'll start with iron deficiency due to decreased intake. In vegetarians, because they do not take meat, actually meat or the non-vegetarian food, they contain the heme form of the iron. As we have discussed previously, the heme form of iron comes from the non-vegetarian food. And this heme form of iron is more readily absorbed compared to the non-heme or inorganic form of iron. So that is why vegetarians are at increased risk of iron deficiency anemia. You must be knowing that vegetarians are at increased risk of B12 deficiency, but now you understood that these persons are also at increased risk of iron deficiency anemia. Okay, because the heme form of iron is deficient in their food. Then infants are dependent on milk. Human milk contains very less amount of iron, that is around 0.3 gram per liter. Cow milk, even if it contains at least around 0.6 gram per liter of iron, but the bioavailability is very poor. Bioavailability is very less. So even if cow milk contains twice the amount of iron that of human milk, it cannot be absorbed readily because the bioavailability is very less. Okay, so infants are prone to develop iron deficiency. Impoverished and older adults, they have decreased food intake, inadequate food intake, and because of this decreased food intake, they can develop iron deficiency. Teenagers, those who are dependent on junk foods, they can also develop iron deficiency. What are the sources of iron? Among the non-vegetarian foods, beef, oyster, turkey, shrimp, egg, lamb. And among the vegetarian foods, peanut butter, brown rice, resin bran, lentils, and beans. So these are good sources of iron. There are certain associated factors. This we have discussed previously, that phosphates, phytates, oxalates, tannate, and carbonates, all of them actually reduce the absorption of the iron. So all these factors can also cause iron deficiency. Now coming to the second subgroup, that is what are the factors, what are the conditions which can cause reduced absorption? So the important ones are the celiac disease. This we'll discuss in the GI pathology section. So celiac disease is a condition which affects the proximal small intestine, and we know that iron is absorbed in the duodenum, that is in the proximal small intestine. So that is why patients with celiac disease, they are prone to develop iron deficiency because of decreased absorption. Apart from that, if the patient has undergone gastrectomy, also there will be defective absorption. There are certain group of people who are at, who have increased requirement for the iron, like the growing infants, children, and adolescents in pregnancy, and also the premenopausal females, because they will have the menstrual blood flow. So that is why all this group of people, they will have increased requirement. Okay, infants, I mean growing infants, children, and adolescents, pregnant female, and the premenopausal females, all of them will have increased requirement. So if the supply is not enough, they will develop iron deficiency. Now coming to the last group, that is iron deficiency due to chronic blood loss. Now remember, this is the most common cause of iron deficiency anemia in high socioeconomic countries. Okay, in low socioeconomic countries, it is the nutritional deficiency or the decreased intake. But in high socioeconomic status, in high socioeconomic countries, the most common cause is chronic blood loss. Now this chronic blood loss can happen from the gastrointestinal tract, through menstrual blood loss, or through the urine. Whenever there is chronic intravascular hemolysis, there will be persistent hemoglobinuria that can cause iron deficiency anemia. And the classical example we have discussed is PNH, paroxysmal nocturnal hemoglobinuria. So this is the classical example for chronic intravascular hemolysis that can cause iron deficiency. Heavy menstrual bleeding or menorrhagia can cause increased blood loss through the menstrual cycle, and that can also cause iron deficiency. Among the GI blood loss, important to answer peptic ulcer disease. Remember, peptic ulcer disease is the most common cause of iron deficiency in adults in the Western countries. Okay, so that is why in adults, if you are getting iron deficiency, you have to go for upper GI endoscopy. But if the adult is more than 50 years, if it is more than 50 years, then most common cause is polyp or colorectal cancer. Of course, peptic ulcer disease can also cause, but you have to rule out polyp or colorectal cancer if the patient is more than 50 years of age. So that is why both upper GI and colonoscopy is recommended. Hookworm infections like Ankylostomata duodenal or Americanus, they can also cause this chronic GI blood loss leading to iron deficiency anemia. Okay, so these are the etiologies. Now we'll see what are the stages of iron deficiency anemia and the pathogenesis. Okay, so actually the stages of iron deficiency is divided into 3 stages. So stage 1 is stage of negative iron balance, stage 2 is iron deficient erythropoiesis, and stage 3 is the iron deficiency anemia itself. So what is negative iron balance? Negative iron balance means the demand is more than the supply. Okay, so demand is more and supply is less. So what the body is going to do? Now body is going to take up the iron from the storage sites. Okay, so as we have discussed, iron is stored in the ferritin, especially in the macrophages. Okay, so macrophages, they constitute the reticuloendothelial system. So now iron will be mobilized from these ferritins inside from the macrophages. Okay, so that is why in the stage of negative iron balance, there will be reduction in the serum ferritin. Okay, so erythropoiesis is not affected at this stage because still iron supply is good to the bone marrow because this iron is now coming from the storage areas. Okay, so that is why the first marker biochemical marker that we are going to get is reduction in the serum ferritin. Okay, now if this stage persists, it will go into a stage of iron deficient erythropoiesis. Okay, so once the storage sites are depleted, once the stores are depleted, now it will slightly affect the process of erythropoiesis. Okay, so that is known as the iron deficient erythropoiesis. However, as a compensatory mechanism, at least at the initial stage, there will be increased erythropoiesis. So in the bone marrow, you are going to get increased erythroid precursors. Okay, we are going to get increased erythroid precursors. That is because of a compensatory response to defective erythropoiesis or iron deficient erythropoiesis. In this condition, along with reduction in serum ferritin, there will also be reduction in serum iron and the transferrin saturation. And also we have discussed whenever the patient is iron deficient, there will be increase in transferrin. So that will cause increased transferrin, increased total iron binding capacity. Okay, so all these features we are going to get in phase of iron deficient erythropoiesis. And in the peripheral smear, you are going to get microcytic hypochromic RBCs. Okay, so hemoglobin content, I mean the hemoglobin in the blood may be normal in this stage, but if you do the peripheral smear, you will get the microcytic hypochromic RBCs. How will you identify microcytic hypochromic RBCs? So if you see, this is a normal RBC, this is a normal RBC, you can see the central pallor is 1/3 of the total volume. But if you compare this with this RBC, as you can see here the central pallor is significantly increased. Central pallor is increased. So this is actually a hypochromic RBCs. Okay, so microcytic hypochromic RBC. Microcytic means reduction in the mean corpuscular volume. So MCV less than 80 is microcytic, and hypochromic means increase in the central pallor. Okay, so you are going to get these RBCs in the peripheral smear. Then if this stage persists, then the patient will go to full-blown iron deficiency anemia, and here you are going to get decrease in hemoglobin. Okay, severe reduction in the transferrin saturation, to up to around less than 10 to 15%, and there will be development of anemia. Okay, and here if you do the peripheral smear, you will get full-blown features of iron deficiency anemia along with microcytic hypochromic RBCs. You will also get pencil cells. You will also get that's right here. Pencil cells, as you can see here, these are the pencil cells, the elongated cells. Okay, so these are the pencil cells. Okay, because the hemoglobin content is low, they will try to take up they can take up various size and shape. So that's why they will make these pencil shaped cells. Okay, so there will be variation in size and shape. So that is known as anisopoikilocytosis. Anisopoikilocytosis. cytosis. Okay, so because hemoglobin content is less, they can take a various size and shape. Various in size is known as anisocytosis, and various in shape is known as poikilocytosis. So anisopoikilocytosis, microcytic hypochromic RBCs, and pencil cells, these are classically described in iron deficiency anemia. And because of this variation in size, there will also be increase in RBW. This also we have discussed previously. Red cell distribution width. Okay. Now coming to the clinical features. So the patient will have features of anemia, lethargy, fatigue, all those things will be there. But apart from that, what else you are going to get? They'll have certain effects on epithelial tissues. They can cause atrophic glossitis. It can cause atrophic glossitis. They can affect the esophagus, leading to formation of esophageal waves. Esophageal waves. As you can see here, this is atrophic glossitis. And also you can appreciate that there is esophageal waves. Okay. And combination of, actually this is a triad of atrophic glossitis, esophageal wave, plus microcytic hypochromic anemia. This is known as Plummer-Vinson syndrome. Plummer-Vinson syndrome, otherwise known as the Patterson. Sorry. I'll just write here. Otherwise known as the Patterson-Brown-Kelly syndrome. Okay, so this is known as Plummer-Vinson syndrome or Patterson-Brown-Kelly syndrome. Now, what else they are going to have? In the nail, there will be spooning of nail. There will be spooning of nail. That is known as koilonychia. That is known as koilonychia. As you can appreciate here, there is spooning of nail. Okay, so we are going to get this Plummer-Vinson syndrome. We are going to get this spooning of nail, that is known as koilonychia. And what CNS effects they can develop? There are two important points you have to remember. One is pica. Pica means craving for non-food stuffs. Okay, so these patients will like to eat maybe the mud or maybe the chalk particles. Okay, or maybe the cement. So craving for non-food items is known as pica. They can also develop a condition that is known as restless leg syndrome. Okay, restless leg syndrome. So in this condition, the patients will be, there will be restless movement of the legs, especially during the night time, especially during the sleep. That is known as restless leg syndrome. Okay, so because of involvement of the CNS, they can develop this pica and restless leg syndrome. Okay, so these are all the features of iron deficiency anemia. Of course, we have to treat them with iron supplementation. Sometimes, most of the cases, oral iron is sufficient, but if there is severe deficiency, and of course, there are certain indications where you have to give IV iron. All those things I'll discuss when I'll discuss about the treatment of iron deficiency anemia. But remember, we have to give them iron supplement. And what is the first marker that is going to, you are going to find in the investigations that the patient is responding? The first marker is increase in reticulocyte count. Increase in reticulocyte count. So retic response is the first thing that is going to happen in the CBC, and you can appreciate this within first to 7 days of starting the iron. Okay, so retic response is the first thing that you're going to see after starting the iron, and you can appreciate this after 5 to 7 days. Okay, so that is all about iron deficiency anemia. Thank you.